Well, good evening, everybody. My name is Emily Rubin. I'm co-founder and CEO of Duchenne UK, and I'm thrilled, along with my co-founder Alex Johnson, to welcome you to this webinar, which is being hosted by Duchenne UK and the DMD Hub on gene therapy, what you need to know. So Duchenne UK has invested around £3 million in gene therapy and looking at some of the challenges in gene therapy. And we really wanted to host this webinar because gene therapy trials are now in the UK. And whilst this is a source of great excitement, this is a very new area. It's a very complex area. And we wanted to try and unpick some of the challenges in gene therapy so that families are fully informed about what being part of a gene therapy trial might entail. We're absolutely delighted to be joined by Dr. Michela Guglieri, who is Neuromuscular Consultant at the Walton Muscular Dystrophy Research Centre in Newcastle, and we're thrilled that she's going to be sharing with us her knowledge and expertise in this area. We're also joined by Helen Graham, who's going to talk to us about her experiences of screening her son for a gene therapy clinical trial. So with that, I hand over to the very capable Michela Guglieri to start us off. Thank you, Michela.
Hello, everyone, and thank you for the introduction. I think that I have a big duty today to just try to summarize, I think, the key point about gene therapy. And I try to make probably a complex story as simple as clear as possible. But I'm glad to have then a session at the end when we'll be obviously open to any question. So as Emily said, I'm Dr. Michela Guglieri. I'm one of the consultants working as a neuromuscular specialist at the Walton Muscular Dystrophy Research Centre in Newcastle. And I have the privilege, to be honest, to be the principal investigator of the first gene therapy trial coming into the UK. Next slide, please. These are my disclosure. Next. What I would like to do today is just really have an introduction about the genetic basis behind Duchenne muscular dystrophy. I know that all of you are very familiar with this, but I think that is an important point just to really focus and try to support a better understanding about the concept of gene therapy and how does it work. And what I would like to do is to just really introduce the principle of the gene therapy, but also how gene therapy applies specifically for Duchenne. And then I will talk to you about what we know about gene therapy in Duchenne muscular dystrophy based on the studies that are currently running, not only in the UK, but worldwide, and the specific challenges that we face in Duchenne. Next. So we all know that Duchenne muscular dystrophy is a rare genetic condition that affects about 1 every 5,000 boys, and this is due to a mutation in the dystrophin gene. The specific mutation causing Duchenne muscular dystrophy is the mutation that leads to the total absence of the protein dystrophin in skeletal muscles. The dystrophin, as I explain usually in clinic, is just like an elastic band that maintains the elasticity of the muscle after each contraction. But one of the principles of Duchenne muscular dystrophy that a completely lack of dystrophin means that the muscle undergo to a constant damage after any contraction. But there is another form, and all of you might be familiar, of a muscle condition that is caused by mutation in the dystrophin gene that is called Becker muscular dystrophy. And in Becker muscular dystrophy, patients that can be children or also adults have a smaller or amount of dystrophin in the skeletal muscle. Is not completely absent, and that is an important difference because the absence of dystrophin in the skeletal muscle leads, so in the muscles, lead to a severe phenotype typical for Duchenne muscular dystrophy, but having some, even if it is smaller in amount or smaller in terms of the size, dystrophy in the muscle, lead to a muscle condition that can clinically, so from a clinical perspective, present differently and is milder in terms of symptom presenting later and develop much slower compared to Duchenne muscular dystrophy. And I think that this is an important concept to understand how gene therapy works in Duchenne. Next slide. So what happens in the muscles when in boys with Duchenne muscular dystrophy when they do not have a dystrophin? As I mentioned, is this elastic band, and the muscle go into a damage after any contraction and relaxation. And this means that this muscle damage means that the muscles that in this figure are represented by nice pink circle progressively are lost, and the hole in the muscle is replaced by connective or fat tissues. And it's quite clear to see that this muscle is not, does not have the same strength as a muscle that include dystrophy. Next slide. It's also important to keep in mind that Duchenne muscular dystrophy is what we call a multisystemic disorder. It does not affect only muscles, but affect also the heart, and as we know, also the breathing muscle, but also the brain. There are other symptoms that are a consequence in a way of the involvement of the muscle. So they can have gastrointestinal problem, they have joint problem, they have spine problem. And these are from, let's say, a medical point of view. And we need to consider that muscle are the largest organ in our body and represent almost 2/3 of our body. And that is, again, is very important to take into account, and that justify why it's so difficult to find a treatment for Duchenne muscular dystrophy. The problem is that the problem is in the skeleton, in the muscle, and the muscle are the majority of our body. And also the fact that it's not only the skeletal muscle, but other organs are involved. But we also know that Duchenne muscular dystrophy is not only a medical condition. It is affecting the child, affecting the family, affecting the community, and affect the education and the daily life of these children. That is why it's so important for all of us to still persist in trying to find involve research effort to find a treatment for this condition. Next slide. Going to the point, what is gene therapy and how does it work? So we said that Duchenne is a genetic condition, so it means that there is a defect into the DNA. And again, how we explain this is there is a mistake in the book that has all information about how our body is made. And the missing information or the incorrect information in the book of boys with Duchenne muscular dystrophy is the one that allows us, is the chapter about dystrophy. So it's quite simple to think about if we miss the dystrophy and there is a defect in a mistake in the book and the chapter related to dystrophy, if I can replace that chapter, then I fix the problem. So the concept of gene therapy is to, in a way, bring into the cells a new gene that is able to produce dystrophy. And that is as simple as it is. Next slide. The problem is, how do we get the healthy dystrophin gene into the cells and into the bodies and into the muscles? And the way that gene therapy works is to bring this new gene is using a virus. Why a virus? The virus is quite convenient because it can be modified and, as you know, can go into any cells. Next slide. And the idea is to use specific virus because obviously we do not want to cause an infection to bring a new gene into the cells, is to use what we call the adeno-associated virus. And you have heard because all the gene therapy that are currently in development use AAV or AAV 7, 8, 9 or other AAV. The concept of the AAV virus is a small virus, and the advantage is that is a benign virus. So if any person is affected by an adeno-associated virus, does not develop any illness. The adeno-associated virus need another virus in order to develop any condition. So there's not been cases that has been shown that the adeno-associated virus can cause any disease in humans. The advantage is also that the adeno-associated virus, you can introduce in a way a gene to take the virus to take the gene into the cells. The virus infects the body without causing a disease, but carry the new gene. And the way that this gene is carried is that the other thing that you can do, you can carry the gene, but you can also attach to the new gene, let's say, what we call a promoter. And the promoter is what helps this gene the virus to target the right body part, and in this case is the skeletal muscle, in this the heart. Next slide, please. But one consideration that I think that is important because it has implication in terms of the potential effect of gene therapy is that the virus carry the new pieces of this gene, but this gene does not integrate. So the virus does not integrate into the body. So if you carry one gene, this gene go into the cells, but does not replicate. Next slide. The second problem is about the idea of having a gene that is carried in by the virus. We have a problem with Duchenne muscular dystrophy, that the dystrophin gene is the largest gene in the human genome. So it's the largest gene that we have, and is too big to be carried by a virus. But then go back to the concept. So we need to find a way to bring in a functional gene that allows the production of the dystrophin, but cannot be as big as the normal dystrophin gene. And here comes to useful the concept that I introduced at the beginning about the fact that we have Becker muscular dystrophy, which is still a condition that is caused by mutation in the dystrophin gene, but allow the production of a shorter or a smaller in amount dystrophin. Next slide. So the concept is that we have a normal length, so a full length dystrophin, that is what we have in all healthy control, let's say. We have boys with Duchenne muscular dystrophy who do not have any dystrophin at all, because the change in the dystrophin gene does not allow the production of the protein. And we have a Becker muscular dystrophy where they have a shorter protein, but is still functional, which means that clinically, as I said, presented in a later onset, much slower progression, and potentially almost normal life expectancy. So the idea of this example that is present in nature is just to say, maybe we can allow the adenovirus to carry a shorter dystrophin gene into the cells that is not allow the production of a normal dystrophin, but a dystrophin that is good enough in a way to make the phenotype much milder. And that is why when we talk about the use of gene therapy in Duchenne muscular dystrophy, the virus does not carry dystrophin, but carry what we call mini dystrophin or micro dystrophin. So is a shorter dystrophin, but has been described in patients with Becker muscular dystrophy who have a much milder phenotype compared to Duchenne muscular dystrophy. Next slide. So, but I think that it's important to say that when we test a gene therapy in a clinical trial, there are a few things that a trial needs to prove. It's not simply as simple to say, does gene therapy work in Duchenne muscular dystrophy? There are a few things that need to work in order to have the clinical benefit out of gene therapy. First of all, we need to demonstrate, and that is the priority, that using the virus to carry the DNA is safe. I mentioned that adeno-associated viruses are safe in a way that if they infect a person, do not cause any illness. But what we do with gene therapy is to give the boys a much higher amount of virus that has ever been transferred in nature. So while we know that the virus in nature does not cause any illness, we still need to prove that giving them much higher doses that they would ever been exposed in nature is still safe. So that is the first question that any clinical trial with gene therapy has to prove. But then we need to prove that actually the virus is able to carry the new dystrophin gene into the cells and is able to reach the right cell. So it is able to arrive in the skeletal muscle and to allow the production of dystrophin in the skeletal muscles. We also need to prove in a way that the dose that we gave is the right dose to induce the production of dystrophin at a sufficient amount to result in a clinical benefit. We also need to know that obviously when we have infected by a virus, our body tends to react against the virus. It's the immune response that is what protects us from infection. So we need to be sure that the body does not react and doesn't develop an immune response against the virus, and does not develop an immune response against the new microdystrophin that has been produced by the adeno-associated virus or by the gene therapy. So these are all questions that the current gene therapy studies still need to prove. We need to demonstrate that we are able to, that we identify the right dose that allow the production of the target, the right organs and the right the right amount of the muscle. And then finally, we need to demonstrate that if the muscle produces the microdystrophin, this microdystrophin is functional and results in a clinical benefit. So there are several questions that is not simply to say, does gene therapy work in Duchenne? But there are several steps that these studies still need to demonstrate in order to see if this is an efficient treatment for Duchenne. Next slide. So what do we know so far? So there are currently 4 companies that are developing gene therapy approaches for Duchenne muscular dystrophy, and here are listed. Are very similar approaches. They use different adeno-associated virus groups, so AAV9, AAV8, or AAV-RH, and they use a slightly different microdystrophin. So the gene or the protein that they will produce is slightly different between the different companies. But the approach is very similar. Next slide. Next slide. So what the data that we have so far, we need to, first of all, to keep in mind is a new approach. So we have very limited data. So the conclusion that we have about safety and efficacy are limited to approximately 40 patients for which we have data on safety and of the efficacy in terms of dystrophin expression and in terms of improving mobility. We have additional safety data from approximately 20 boys that are currently taking part in a double-blind placebo-controlled group, but that for which we do not have any information about the efficacy, but we have incoming data in terms of safety. What we know so far in terms of efficacy is that all approaches overall, someone more, someone less, result in an increase in dystrophin expression, and there is a positive trend in clinical outcome. Some of these studies have not been able to show so far a statistical improvement in terms of clinical outcome, and you have heard about the North Star, but all of them at least show a positive trend. Next slide. In terms of safety, what we know is that the overall is well tolerated. The majority of the boys can develop some flu-like syndrome, some fever, feel vomiting or nausea after the injection. It has been reported that there is an inflammatory response of the body that can result in an increase in the liver enzyme, which means that there is a toxicity in the liver caused by the gene therapy and by the immune response against gene therapy. But there are also less common cases, but have been reported in most of the clinical trial with gene therapy in Duchenne currently running. That is the fact that the body reacts against the virus and there is an inflammation, an immune response against the virus. And this is what we call is a complement activation, which can lead to what again is called a typical hemolytic uremic syndrome, which means that the boy develop the immune system of the boy react against the virus. And what the result is that we have a drop in the platelets with the potential risk of bleeding and a toxicity in terms of kidney function with the potential requirement of dialysis. There have also been cases that where the response of the body against the virus and potentially against the microdystrophin, but is still very unclear, can result in what we call a myositis, so an inflammation of the muscles and an inflammation of the heart. So although it is safe, the side effects profile, there is a side effects profile associated with gene therapy, which required a good knowledge about the approach, a good knowledge about the potential risk and how to treat this potential risk. Next slide, please. But also we need to take into account what is specific for Duchenne that is a challenge in terms of gene therapy. Because the body can develop an immune response against the virus, gene therapy can only be administered once. If I give a second dose of gene therapy, the body will have developed antibodies which will attack the virus and therefore will not be effective. The problem, and that is the difference, for example, of a gene therapy approach in Duchenne compared to a gene therapy approach in SMA or in spinal muscular atrophy, is that the target organs in Duchenne is the muscle. And the muscle is not a static organ. If you think about it, is in constant regeneration. If you have a fall, if you have a trauma, the muscle has a damage and automatically repairs itself. The problem is that if there is this regeneration, the gene therapy that has been the gene that has been brought in by the adenovirus will not be able to be present in the regenerated cells. Next slide. And the other problem is that we give gene therapy in Duchenne and our children. And again, the muscle is not a static organ. So they grow, and therefore there is a potential of dilution effect with the gene therapy with time, which we still need to learn from. It's something that is still expected, but we know very little about it. Next slide. So overall, when we talk about gene therapy, I think it's important to say it is an exciting time. Is an approach that from a scientific point of view, from a medical point of view, has very good potential. And the preliminary result in terms of dystrophin expression and the muscle function is absolutely promising, but doesn't come as an easy approach. There are still significant challenges. The first one is regarding the safety. The second one is about how do we target a tissue that actually represents the majority of our body part? How do we measure the efficacy of the treatment? And when is the best time to give gene therapy if we take into account the natural growth and we take into account the regeneration? Should we give it to very young children who are still growing quite fast and therefore we expect a more dilution in a way of the gene therapy? Or should we give gene therapy later when the regeneration and the growth is less active? On the other hand, we have less preserved skeletal muscle. And then there are now emerging concerns about whether it's really a treatment that is applicable for all boys with Duchenne. There's been an announcement from the Pfizer study that is ongoing that some boys with specific mutation in the dystrophin gene might have a higher risk to develop an immune response against the gene therapy, and therefore might not be the best approach for them. So with this is really my introduction about everything you need to know about gene therapy. There is much more that you need to know, but I hope that I give a little bit of introduction to really make the question and the discussion on the plate. There is just a brief question about how recruitment in gene therapy is. And I think that the only thing that I want to mention, and then is open to discussion, is the fact that there is obviously there is an interest in terms of offering the possibility to take part in gene therapy trial to everyone, and not just based on the geographical distribution of the center that is taking part in the gene therapy. But there are some considerations. And the one that I always mention is that these are clinical trial. The majority of them has a placebo control group. So even if you take part, you might not receive gene therapy. And the priority is the safety of the patient. And not being recruited in gene therapy does not mean that you have missed the opportunity of treatment. You have missed the opportunity to take part in a clinical trial, but the efficacy of the treatment of gene therapy still need to be proven. And there are the priority in terms of selecting the patient for gene therapy is based on where the patient for which I feel safe. And for example, having patient traveling when there is a high risk of side effects might not be the best approach. But also patient that will be informative. And I can't emphasize enough that the worst result of a clinical trial is when a clinical trial say, I do not know if the trial works or not because I selected the wrong population. The study need to show me, and the commitment of families and the clinician in taking part in such complex and somehow risky clinical trial is at least the trial need to be able to answer the question, does the drug work or not? And that is all consideration that we need to take when choosing or selecting patients for clinical trials. But obviously there is a lot of work going on, and the priority is the safety of the patient, but also equality as much as we can in terms of access. And obviously part of the discussion today is regarding the choice about, from the family point of view, about how do you make this decision about taking part in gene therapy study or not taking part in gene therapy study. So again, I look forward to the discussion with Helen, and I just want to mention a few concepts about how do we manage the discussion about participation in clinical trials. And this is valid for any clinical trial, but has some specific implication for gene therapy. First of all, when we take part in clinical trial from a clinician point of view, we need to follow what we call the good clinical practice. And it's important because there is a regulation that tells us that the principle of recruiting a patient in a clinical trial has to be ensure that we maintain the right safety and the well-being of the subject, and that is the priority. Next slide. And how do we do that is through the consent process. The consent process is when we need to explain the study to a family to allow them to make an informed decision about whether they want for their child to take part or not. And it's much more complex in children compared to adults because the parents has to make a decision for a child. It's not you don't make a decision for yourself. And the general principle is that I need to provide the family with this information prior conducting any study-related procedure. And the specific for the UK regulation, if the clinical trial involve children, so minors, we should put any effort to inform the child about what the research is about. And we should explain the clinical trial in a language that is appropriate for the subject at that specific age. But according to the UK regulation, any child aged 4 and older should be informed and should provide a written or verbal assent to take part in the research. Next slide. But that is the, promise I don't go through all the list of this, but is what we need to explain according to the good clinical practice during the consent process. Next slide. That is more specific for gene therapy. And if you think about the introduction that I gave to gene therapy, you might understand how complex is all the consent process around it, because we need to explain, obviously, the background, how does gene therapy work, why there are some inclusion criteria, why there is a placebo group, and how this is defined. We need to explain what the study involves, so how many visits, how the duration, what are the procedures, including, for example, a muscle biopsy. We need to explain the safety profile and therefore provide all the information that I summarize in a way today in details. What are our knowledge in terms of safety and benefit that are available to the point that I consent in the patient? And is what is expected, what we do not know, how do we monitor it? And then it's talking about the alternative option, because the patient has to be given all the option in front of their table. And that is what makes the consent process complex. Next slide. So this again is my introduction. And I think that what I would like to have now is more a chat about, because Helen is one of, is a mom that has been involved, has actually lived in first person the consent process regarding gene therapy. And I gave a little bit, in a way, the clinician perspective, and I would like to just have Helen to present to you a little bit what is how the consent process is from a parent's point of view. So Helen, do you mind to just explain a little bit your background and what was your experience?
Sure, yeah. Hello, everyone. My little boy is Louis. He's age 7. He's one of 2 children, but he's the only child that I have, 2 boys, but he's the only one with Duchenne from a rogue gene. Very happy, healthy little boy, and he's always been under Dr. Michela's care since he was 2. It was discovered fairly early, picked up through a CK test for some other random tests. So we've known from sort of 18 months or so that he's had Duchenne. He's been on a few different trials through the Centre of Life for alternative drugs, for Vamorolone. And then we've got to this point of to be considered for gene therapy. There was sort of 2 routes for me to take or look at this point. It was the Essence drug, which was the weekly infusion, and then there was the gene therapy. Luckily, Louis was one of the children who fit all the criteria, matched the criteria, and was taken through to the screening process, which was a very lengthy process. Obviously, Michaela had to explain everything to us in great detail. It was sort of a 3-hour session about everything she's explained today, obviously in a lot more detail. And then the next session was Louis had to come with us and be told exactly what was going to happen and actually sign his own declaration to say that he was happy to take part in the study. But obviously, if you tell a child who can't do what his brother does and all of his friends do, it may help to make your muscles better and stronger. He's willing to try anything that's going to help. So he was quite keen to sign his name on the line and agree to take part. We went through the screening process. Louis had the bloods taken and they were sent off to America, which is, again, is quite a lengthy process. It takes about 3 weeks. And unfortunately, in Louis' case, there was some retesting that needed to be done. So it was sort of about a month between the blood samples being taken and the results coming back to say that Louis wasn't eligible. He had the antibodies to the AAV virus, so he wouldn't be able to participate any further in gene therapy, which obviously was heartbreaking at the time. And the impact of that on Louis, maybe the consent process, and sort of he still asks now, when is he going to get this new process that's going to help him? Because it had been explained to him in such detail. He'd been sort of given maps as to what was going to happen, all the processes of all the appointments he'd go to, what would happen, what would be done, literally really well explained to him. But at the point, maybe a little bit too early, because I get that we have to consent before this process can take place. But actually, Louis was sort of bought into this process to then not meet the criteria and he can't go any further. So I talked with Dr. Michaela about the process and how it affected us as a family. Another part that I've missed, sorry, is that both parents had to sign the consent. And in our family, it's not the same, we're not together. So it's quite a difficult process to persuade his dad to come and sign those papers, which in itself was quite traumatic. And then didn't make it to be able to progress anyway. So Dr. Michaela and I talked about different timings, different processes of what could and couldn't be possible for the pharmaceutical company. Is it something that we could sign to say, yes, we're happy to do the blood sample and leave it there before any further involvement was with Louis or other parent? Just the options of that really, which was quite a strain.
Can I just add in a way? So what happened with Louis is that he had antibodies against the AAV, and obviously the problem is that in that case, he will not be eligible for receiving the gene therapy, because it means that his body will react against the gene therapy itself, so will not have any benefit and potentially have all the risk associated with an immune response against the virus. The problem is, I think, 2 points is that the problem is that because the AAV9 is not a virus or AAV are not virus that cause disease, there is no availability in the NHS, or actually there is no lab in the UK that perform the test. So the only way for us to test whether a person has antibodies against AAV is at the moment is within a clinical trial. And specifically for most of the gene therapy trial at the moment, the lab is based in the US and take a few weeks. But it's true because it's part of the trial, the testing, this is a procedure that is done after the consent process. And then is where there is all the stress. And I think that one thing that I would like to ask Helen is, obviously for you, what was your feeling in a way, because you've been through the process and you are there and you listen for 3 hours talking about, I guess, a quite complex amount of information. And I would like to understand what were you thinking while I was doing the consenting, and how much of that information in a way you retain, how much scared you? What was your feeling during that process?
Mm-hmm. A lot of information to take in, but obviously when it's your child, you do what you think is the best thing that is for them. Listening to you talk about the process, what could happen, what is the possible benefits, what may happen. Obviously there's no guarantees, it's a trial, but the expected outcomes or what it may help. Anything has to be better than what it would be without giving it a shot. Obviously we know what Duchenne do to our children if we don't have some kind of answer or some kind of drug that's going to delay or help with that process, and to not do anything wasn't really an option. Yes, I understood the risks. Yes, I understood the possibility of things going wrong, but when it's your child, you just have to do what you think is the best for them. And in that case, the only option to me at that point was to go ahead and do that for Louis. But obviously things don't work out that way. Things happen for a reason.
Exactly. So you now, obviously, we've been involved with Helen in several discussions of this type. And I think that Helen now have heard about the potential side effects at least 3 times. So during the consent and then a few times. Do you have a different feeling after having listened in a way? Also because you have listened in a way the safety profile during the consent process, which I guess is quite stressful. You're there and you're there to take part. And then you have listened at the safety profile in a more independent way, because you knew that at that point, Louis was not eligible for gene therapy.
Mm-hmm.
As your feeling or your opinion, would you do things differently?
I think one thing I hadn't picked up on the initial conversation when I listened to you talk about it was the chance of it being a placebo, and the fact that Louis could be tested now and he might not have had the antibodies, but during that first year of treatment, he could have been on placebo. And then when we get to the end of year 1 and he's eligible to have the gene therapy, at any point during that year, had he developed the antibodies to the AAV, he couldn't progress anyway onto year 2, which would have been the actual treatment. So that was something that I hadn't really picked up on or listened closely to first time around, which I've now picked up in previous conversations. Yeah, things happen for a reason, as you say, and it wasn't meant to be this time for Louis, rightly or wrongly.
And I have another question, because obviously there is what we discussed previously to say, actually, and as a conversation that is ongoing, not only for Duchenne, but in general for gene therapy approaches, about whether the antibody testing could be available, ideally through the NHS, completely outside any clinical trial. But the other option, because that is not a reality now, and we discussed, and as you mentioned, about whether even just to say we have 2 phases of consent, we have a consent where I just ask you to consent for antibodies and do not mention in a way the full spectrum of gene therapy, because it might not be an option for you at that point.
Yes.
And then once you have the result of gene therapy, go through the process.
Absolutely.
Do you think that would you feel, and I know that might be difficult, but would you feel any pressure about the fact that at that point you have been told your boy does not have antibodies, and therefore you feel a part of the is what you say, things happen for a reason, that your decision about taking part is not then based on the information that you are provided, but more about someone has decided for me, so this was just destiny in a way, so things happen for a reason, and or feeling that I'm being lucky that my boy does not have antibodies. How can I now refuse the treatment when other boys whom I want actually can't because they have antibodies? So do you think that you would have felt this pressure? I know that is all hypothetical, but
yeah, it's a whole hypothetical thing. I think the whole pressure on the overall decision, if it was able to be split into 2 sections, you sort of said yes to the blood tests first, and then it was the process of thinking about what you do next. I think if you've already agreed to do that process from day 1, whether on yes or no, you get the blood test and has the antibodies, you've already committed in that you're prepared to do this for your child. It just takes a little bit of the pressure away. Maybe if the blood test was done first, and then that lowers your option. If you've got the antibodies, it's the end of the road and you haven't got to involve other people into that problem or that worry or that concern. And especially the impact I've seen that it's had on Louis. If I could reverse time and let him have just the blood test, and for him to have known nothing, he's then none the wiser of what he's missed out on or what could have been. But as I say, he keeps mentioning, when is this going to happen? And it's not going to happen for him now. And I'm just sad that he was sort of involved in that at such an early stage that maybe he didn't need to have been.
I think that is an important point also, because, for example, in other countries, children below the age of 6 do not need to provide consent or assent. So it's not a specific requirement when it is in the UK. But as we discussed, I think maybe the involvement of the child in a different way. But on the other end, I think it puts also some pressure on the child to say he's not informed, he take the blood, and then the decision is already made for him in a way. So there are pros and cons, or
yes,
some ethical concern behind that decision. I can carry on to talk with Helen for hours.
Thank you so much, Michaela and Helen. Thank you so much for sharing that very personal story. I'm going to hand immediately over to Alex, who's going to chair the next discussion session.
Helen, just a big thank you from me. You're so brave sharing your story, and I honestly, I can't imagine how difficult it was for you, but to come on and share and help other people understand this issue, because it's something we don't understand. One thing that I did, just quickly, I'm going to jump in with a question myself. Do you feel, obviously the consent process was 3 hours long, which, you know, my son is on a clinical trial and it was nowhere near 3 hours long. So obviously it was a very in-depth session. Do you feel any counselling would have helped you before or after this? And the same for Louis, you know, with him asking these questions now, do you feel any kind of psychological support would have helped you through this process?
Well, I'm quite a strong person. I do shoulder quite a lot of strain and pressure myself. I've had to deal with Louis' treatments and appointments myself since he was obviously really small. So maybe not so much in my case, but maybe for Louis. I do still think there might have been a slight impact on him, and he does still ask a lot of questions, which trying to find the right answer to tell him, I don't really have the right answer. And he doesn't fully know the extent of his condition. We just talk about it as tired legs, tired muscles. Obviously, I'll build that knowledge up as and when, but when he's still only 7, I don't feel the need to tell him the full extent of it. So yes, maybe somebody for Louis to talk to rather than just me might have been quite helpful. But we just keep saying something else will come along. He's obviously, his medicines he takes on a daily basis, his steroids, he thinks that sort of new medicine that he's trialing and helping. So to him, he is taking new medicines because they were different to the medicines he did originally have. So I think for now, that's maybe sort of masked the issue until something else comes along.
Helen,
I think something. Sorry, go on, Michaela, you go.
Sorry, no, just because actually it's an important point to say. Do you remember when I gave you a ring to tell you the results?
Mm-hmm.
And from my point of view, it was very difficult because I was thinking, is it better to call her when I know that she's at home?
Yeah.
But if she's at home, she will be with Louis. Or is better to call her when she's at work, or it's supposed to be at work at least, when might not be appropriate for her to take a step back. So you want to add anything on that, Helen?
Yeah, well, I'm in a very lucky position that I just literally work around. I can see the RVI hospital from my office window. And obviously Louis been part of the CRF unit on the last trial for a few years. So he's really quite close to the nurses who were up there, as am I. So they offered me straight away some support to come into the unit and sit and chat through with them what other people who I was sitting with probably didn't understand technical terms or how it was all working, which at the time was a great support because that day was the worst. I mean, yes, I didn't feel great for a few weeks, but that day when Michaela rang me was the worst. And they were sort of there to support me literally out of my office window, which I'm very lucky to have so close, I suppose.
This was another thing that maybe also we need to think about how we can improve this communication, maybe planning a face-to-face, because for some family, especially if they are far away, receiving that news on the phone might be a little bit too much, and also might not be the right time or the right context. On the other hand, if a doctor calls you, you know that is what they want to tell you. So maybe it's also that.
Yeah, booking a face-to-face appointment, we talked about this, and maybe if it's good news, you know they're going to ring you and tell you before your appointment. Maybe it's the downside that if you've got a face-to-face booked in appointment and you haven't heard anything before that appointment, does it sit in your mind that it's going to be bad news? I was sort of on the hop, really on the back foot, that when Michaela rang me, it could have been any day in that week or any day the week before. It was just sort of waiting for that call. So I don't know if it would be worse to build up to an appointment of a specific time on a specific date. Is that worse? Probably. I don't suppose there's any good way to find it out, really.
No. One thing that I think we've talked about sometimes is the DMD Hub with regards to clinical trials and making decisions to take part in clinical trials. Obviously, it's important to have the discussion with the PI, you know, about the trial, because Michaela understands it really well. obviously this was a really complex trial, and you know, I read the list of side effects then and I was like, oh my gosh, you know, I was thinking if Jack saw those, he's 13, he'd be like, no way, mum, am I going to take that? Would it ever help, do you think, to sort of come away from the appointment and talk to somebody independent about the clinical trial, to talk through the risks and the benefits? Obviously, you had also options of other clinical trials. Like, essence, do you think discussing all of that with anybody independent from the situation would have helped you?
In hindsight now, possibly, but I was just so keen that Louis had got a space. I knew there was only limited spaces for more children than there was spaces, and I was just more than happy that he got as far as he had. I was quite willing to progress quite quickly, but obviously looking back in hindsight now, when you're not in that position, or you're not going to get to the next step, then somebody independent might have been used to chat to, but that's it in hindsight now, I suppose. Yeah.
We've got some questions that have come through on the chat. So the first one is it possible to tell the child about inclusion and exclusion criteria? So obviously some discussions did go on with Louis. How much was explained to him about the inclusion and exclusion?
Well, Louis wasn't at the first initial 3-hour appointment. That was just myself and his dad who had the conversation with Michaela. We would have lost Louis 2.5 hours.
I'm not so bad to keep 7-year-olds 3 hours listening to me.
So he just had the sort of the next day appointment when it was a little bit of information and the bloods, and he was told the basics of what would happen. And of course, that's where his knowledge now is from, because he remembers. You think he doesn't listen to when other people are talking, but he takes in a lot more than what you think.
Yeah.
And then he sort of repeats things afterwards, which you think he's never even heard, but he obviously has homed into other people's conversations. So it was probably just as well he wasn't there for the 3 hours, but the bit he was involved in, he has remembered quite a lot of, hence the questions.
Well, just a quick comment from Victoria Selby. She says, not a question, but a thank you so much to Helen for sharing that valuable knowledge with us. So emotive and important for health professionals to hear. Great webinar. Thanks, DMD Hub. Now, there's a comment here from Lawrence Woolard about some work that they've been doing on informed consent for haemophilia gene therapy that may be helpful for us, so we'll definitely look at that. So thank you for sharing. Now, Michaela, I think this is a question for you, and I don't even know if you might be able to answer this. Can you see the question from Mary?
Yeah.
Hello, although it is a different virus, do you know if anyone is studying the mutations of coronavirus, particularly the mutations from D614 to, I think, N501Y, where the virus has increased from replicating times 1,000 to replicating times 1,000? Can we learn from these mutations to help with the research to increase the size of the AAV to enable it to hold a fuller dystrophin protein?
Try my best. No, I mean, the answer is relatively simple about no, I don't think that anybody is looking into that yet, because also you can't really compare individual mutation in a virus and say, can I transfer that individual mutation necessarily in another virus? And then we need to be careful, because in a way, we do not want the virus to replicate too much. So we already have the concern about the fact that if we give a very high doses of adenovirus, so it's not that I want to replicate the virus, I want the gene to go into the cells and continue to replicate in new cells. But then there is also a potential risk of how do I control this continued replication. So I don't want the virus to replicate excessively, because it's not the benefit itself of the virus. They can be actually dangerous to increase the potential response of immune system. I want the DNA that has been integrated in new cells to continue to replicate within the new cells. So the mechanism is different.
Okay, I'm going to nod and pretend I understood that, Michaela.
No, so no, Alex, and you should understand, but the point is that we don't want to give more virus, we want to give more gene in a way. So we want more cells.
A question. So obviously this issue of pre-existing antibodies, at the moment, there's varying estimates of how many boys this potentially could affect. Have you seen any latest statistics, Michaela, on how many boys we think will have pre-existing antibodies?
To be honest, no, and there are some emerging data, but again, until in a way the antibodies is wider available, making any conclusion about the frequency of the positivity is still related with relatively small number of boys that are currently tested at potential participation in gene therapy. So we are not talking about big numbers. And that is why I think that we need to be very careful in say that is the percentile of boys that has the immunity. We know that the immunities increase, I mean, the risk of having antibodies increase with age. So if we take babies as a lower risk compared to older, children, and adults has a very higher risk to have antibodies against the virus. So increase because you have much higher risk to exposure to any kind of virus. But to give you an example is that at one point was reported in the initial study was reported that in young, within the population, they reported a frequency between 20 and 70%, which means anything and everything. Within the Duchenne population, they were reported in the initial statistic about 40% of children between the age of 5 and 10 having antibodies. Then there was an initial counting of when some site in Spain started to take part in gene therapy, where the first few boys, all of them has antibodies. And then they were thinking, well, maybe actually Europe has a much higher risk to have antibodies compared to the States. But 3 months later, other 3 boys were tested. They were all negative. So making conclusion about the frequency when you test a very small representation of the population, I think that is very dangerous.
Can I just quickly jump in and ask you something, Michaela? So do you report back to the pharma companies about how difficult experiences like Helen's are? And do you know whether any of those companies are looking at this issue of pre-existing antibodies and whether anything can be done?
I think that everybody is aware of the issue. We have reported back, and I think that we need to, there are different levels where we need to report back the experiences, the sponsor, but is also ethics committee when they review the consent process, how this can be optimized. And I think that sometimes it's really the patient voice and the ethics committee that can make the sponsor change their protocol to say as a requirement, you need to split the consent process. So is work that I have to say has been raised, but need to be done in the future. There is an interest, obviously, in terms of making the antibodies more widely available. The problem that there are no, at the moment, there are no labs able to do the test, so that routinely perform the test, and all the one that they do are private labs. That is the one that subcontract the sponsors. And there is one argument to the fact that what is the real interest? So it's not a real impact for taking part in gene therapy, because you can be tested, and you can be tested, as Helen mentioned, you can be tested negative today, and then you are screened for gene therapy in a month, and at that point you are positive. So there is this component. I think that would be still an interesting to understand how frequent it is, and also we need to learn. I mean, if we think about, we have now gene therapy approved for SMA, and within that setting, we are able to give result of antibodies within 48 to 72 hours, which is a much shorter turnaround compared to what we have now in gene therapy trials. So I think that also for Ellen experience, if we knew that that result would have been available in 48 to 72 hours, the full process would have been different, because also for my point of view, the consenting, I do the test. I mean, yes, we can have a quick chat, but in 72 hours, we have the full discussion. When here, the dilution is that I need to do several procedures within the first 3 to 4 weeks while waiting for the results, in order not to reduce in a way the risk that then you become positive if the screening process lasts 3 months. So I think that there is no one only one solution to the process, but there is more direction that we need to work on.
Okay, thank you. We're joined actually by our Director of Research, Alessandra Guetta. Obviously, Emily and I have been aware of this issue of pre-existing antibodies for a few years, so I just thought it might be nice if you could touch upon some of the things that we're working on to try and overcome this issue.
Yes, sure. Good evening, everyone. So I guess in research, our focus in gene therapies is very much around the issue of delivery that Michela mentioned at the start of our presentation. So making sure that we can find more effective technologies to deliver the gene to the cells that don't rely on viral vector delivery. And obviously, if we achieve that, that will also address the challenge of antibody, pre-existing antibody to the viral vector. So for us, this is a really key priority that we're trying to drive through research. And we're currently funding 3 projects that are looking at this particular space. And also we're really interested in understanding better the immune response from the body to these therapies, so that we can better tackle this issue of antibody, but also the natural body response to gene therapy, regardless of whether they're delivered through a viral vector or any other type of vector. So we're very invested in really addressing these issues and working with companies to really maintain them, I guess, focused on this challenge of really improving the current generation of gene therapies, and thinking, how we can make these therapies more accessible to a much larger population of children with Duchenne.
Thank you. I've noticed, Leslie Wegg, you've raised your hand. Can we unmute Leslie?
Hi, thanks everyone for the update. I was wondering if you had any more details regarding one of the slides, Michaela, quite early on, where you said that it may be possible or it may not be possible for all mutations to be covered by gene therapy. Do you have any more information on that?
Yeah, so the point is that it's still something that is totally under investigation, but there are some suggestions that so if we look in the adverse event that have been reported so far in the Pfizer study, it seems that children that carry a deletion affecting exon 29 and 30, or exon around 13 to, I need to check exactly, but around the exon 13 might have a higher risk to develop an immune response. These are elements that are based on very small cohort, so it's something that we will learn in the upcoming months, but that is what is currently being changed in terms of inclusion-exclusion criteria for one specific trial, so it does not apply to all trials at the moment. So I think that is very difficult to make conclusion, and I think that any question regarding specific mutations really need to be addressed on the individual case, and might vary from one study to another.
Yeah, thanks very much. I'm sure it's really difficult when you've got such small numbers of participants in the trial to understand how those different mutations are going to be affected. So it must be really challenging, but thank you very much.
And I need to apologize because there was a question and I said that I was answering live, but actually was trying to answer, I made a mistake, sorry, technology. But question about whether the dialysis was temporarily, and I think that is fine for me to report that yes, the adverse events that were reported, including the dialysis, resolved, required intervention and specific treatments, but they resolved and the children are fine.
Michaela, thank you so much for that. Alex, I think we're running over now, so we might have to wrap up. So I just wanted to thank everybody for dialing in and listening to this really fascinating hour. I really want to thank Dr. Michela Guglieri for sharing all of her expertise and knowledge in this area. Thank you so much. And to Helen as well for sharing such a personal story. I think everyone on this call will have been affected by the journey that you went on, and we really salute your courage and determination. So thank you very much indeed for sharing. I know that can't have been easy. So that was our webinar on everything you need to know about gene therapy. You can, of course, keep up to date with clinical trials in the UK on the DMD Hub Clinical Trial Finder. And we look forward to seeing you all again next time. Thank you very much.